So today we're going to be spending an hour looking at early intervention considerations, and I'll explain the specific areas we're looking at and our definition of early intervention in the context of this webinar, and particularly looking at how adaptive equipment and postural care equipment can implement and can complement early intervention strategies. Um, Today, you've got myself, Kieran Murphy, my colleague, Kaylee Cooper, and my other colleagues from the marketing team, Rosalind and Chris. So we will be doing a short, informative webinar over three stages, focusing on prone lying, sitting development, and abducted standing, particularly in high-risk infants. And then following each stage, my colleague Kaylee will be doing an informative demo of particular products that will help complement practices in those areas. So just moving on. Here's the main introductions of the two people that you see today, myself and the lovely Kaylee. Kaylee is our National Clinical Training Manager, and I'm a Clinical Partnerships Manager. We both have a background in therapy, both qualified physiotherapists. Kaylee has extensive experience in the medical equipment industry and particularly working with paediatric equipment. And I continue to work on a private and locum basis as a physiotherapist alongside my job. Just a little overview of what to expect today. We're going to try and define early intervention for the context of this webinar. We are going to draw upon learnings from cerebral palsy and clinical research into strategies for cerebral palsy. We'll provide a brief overview of features of typical paediatric development, more specifically looking at neuroplasticity, skeletal development, and gross motor skill, and how those can factor in to some of our equipment prescription considerations. The main focus of the topic today is gross motor development, particularly in the positions of prone, lying, sitting, and standing. And linked in with that, we're going to highlight the benefits of tummy time, development of sitting posture briefly, and benefits of particularly abducted standing, with a discussion about the benefits of multi-positional standing from what we've learned earlier in the webinar. And the main thing we want to kind of underpin is thinking about how adaptive equipment and postural care approaches can play an important role in those at high risk of developmental delay. So first kind of question is what is early intervention? It's a very, very broad topic, and it depends on the context of what we're talking. What we've got there in that first image is examples of the fast approach to detecting stroke, and also an image of early psychosis intervention from an intervention team within Canada. We often, because of where we work, we think about early intervention being in those children that are in infant years, but actually early intervention is applying preventative or detective services or encouraging services at the earliest point. We're in context of the user, of the person that we're thinking about, or the patient that we're thinking about. So it might be early detection of stroke symptoms. It might be early detection of mental health issues and the appropriate referral. Because it's such an umbrella term as well, we've got to consider, is early intervention just one practice? Is it just detecting a diagnosis? Is it just treatment? Is it just management? Is it single therapy to disciplinary approach? Is it just an early referral to audiology for those showing sign of hearing delay? Or actually is it that might signpost the child having maybe more gross motor developmental issues or developmental delay, and actually we need a multidisciplinary involvement. So it's understanding again the context of early intervention. It's wide ranging. It's very difficult to define depending on how we're discussing the process. In general, yes, it could be just generally an approach to promote development of children under the age of 2 in this context. But for this webinar, we are focusing on gross motor skill and postural development. And then there's also the discussion of early or on-time approaches. You'll see later in this webinar, we'll talk about typical gross motor milestones and the ranges for that. And if we are providing postural care support around typical ages for children who are typically developing in those who are atypical. So for the purpose of this webinar, we're looking at a program to support postural and motor development in higher risk infants. Very general definition. So as I'd mentioned at the start, we can draw upon what we are learning and what's emerging from the cerebral palsy population, particularly with emerging evidence from therapists in Australia. This is, if people still have their camera and microphone on, if you don't mind just turning it off just to help with the streaming of the webinar, thank you. This is a really nice visual of the progress of developing cerebral palsy. I think it's the word palsy is just hidden behind that image there. And in recent times, in the last few years, we've been international clinical practice guidelines have been established for early detection, diagnosis, and early intervention strategies. Because we have so much extensive data and evidence in children with cerebral palsy, thanks to the surveillance pathways that we're getting established worldwide, and we're moving away from that traditional thinking that symptoms and outward presentations of cerebral palsy are silent between the ages of 1 to 2. Actually, we know that for those infants that maybe have typical birth, that actually there are assessments such as the Hammersmith infant infant neurological examination and the general movements assessment from the Pretzel qualitative assessment of general movements. They can help support us early in the diagnosis or the detection of cerebral palsy alongside MRIs. And we're now getting the shift in the view that actually we want to be aiming to diagnose and detect cerebral palsy before the age of 2 years, because symptoms are presentable before those ages. It's not dormant. Obviously, we've got indications for risk factors in the antenatal period that can help us potentially diagnose early. But it's these strategies in those births that are more typical that we can use our skill set and use our knowledge of assessments, not just the Hein or the GMA, what we use in practice in terms of understanding developmental milestones, what we understand in terms of sensory integration and integration of typical reflexes, to name just but a few examples, to actually be proactive in our implementation of diagnostic approaches, preventative approaches, and also treatment and management approaches. And this gives you a brief overview of the pathways that Ayana Novak and her colleagues produced as part of those clinical practice guidelines. And we don't have time to go through these today, but all these references will be included in the slides that you will receive next week. And again, with cerebral palsy, we know we have classification systems that can guide us potentially on predicted motor outcomes. And we know that those with the most severe motor impairments younger are also likely to have the most severe impairments as they get older due to growth. And there's actually going to be a likely deterioration in motor control and function because of the deterioration in their postural control and deformity, changes in deformity and contractures due to orthopedic changes and immobility. So we know quite early that we can potentially identify cerebral palsy and also use predictive outcomes in regards to motor function and development. So we need to think about, actually, is there a way of implementing active early strategies to reduce this deterioration in function? It's not going to always happen. We know that as therapists, that children with severe motor outcomes and severe motor impairment, no matter what we do, there's not going to be an improvement in function. But being proactive, moving away from passive strategies, can be really important to support development, and also challenging these classifications, because the classifications are useful for practice, but they don't necessarily see the child, their environment, their support, and still their potential. So some of the early strategies that are recommended are early diagnosis through clinical assessment and appropriate and valid assessment measures, early detection of motor severity, as we discussed, to help guide us in likely motor outcomes, surveillance programs that we're seeing all around the world, particularly the CPOP and CPIP pathways for preventing hip dislocation and reducing hip migration. Active interventions is very highly recommended, particularly child-initiated movement and specific motor training, and particularly repeated practice, which we'll touch upon in the next couple of slides. One thing that's really advised and really drawn upon in terms of successful outcomes is that parental support, collaboration, and valuing parental concerns in terms of delay, because they know their children the most, they know their children the best, and actually valuing their opinion to establish that collaborative working partnership will help in terms of applying postural care and interventions. And then emerging kind of concepts recently in the last few years is also this discussion on environmental enrichment. So this is, again, a really nice overview of what environmental enrichment may look like. It's not just purely doing practice of gross motor skills, if we're thinking in the context of gross motor development for this webinar. Sensory stimulation, cognitive stimulation, and social stimulation in those early years are hugely interlinked with the ability to improve in gross motor skill. And it's really important to factor in of the child's development in these early years when growth and development is particularly explosive. Now, this is taken from a study looking at children with Rett syndrome that's typically seen as a regressive disorder. It is a regressive disorder. And if we took that at face value, we might kind of be passive in our approaches in terms of development and active interventions and encourage development because there's this expected regression in these children. However, this is a nice study to show that there can be positive changes in terms of skill and development in children that we know are very vulnerable and also likely to regress at an early age. On there is also a really nice story from a team in Bumblebee Therapy down south in the UK. They used elements of environmental enrichment with a young child with Rett syndrome, a bit later than what we class maybe as the early years, but they showed that positive environmental enrichment that stimulated cognition, sensory, social activities, and also thinking about timing and also doing it appropriate to the child's fatigue and needs had a positive impact on their gross motor function and development. So that'll be a clickable hyperlink that we'll send to you. And this is where we tie into neuroplasticity. So we could do a whole presentation on neuroplasticity, and I'll try my best to be as succinct as possible. But this is something that's really important that we know from learnings and understandings in children with the cerebral palsy, but this is looking at typical development. Now, neuroplasticity, put simply, is the body's ability to create and reorganize neural pathways within the neural system. In children who are typically developing between 0 to 2 years, it should be at its most explosive. So what you can see in the top left-hand corner, if I can just do the laser pointer here, some examples of brain cells and the typical development of the brain cells and neural pathways in these first few years of life. So the little black dots that we see here are neurons, and they're like commands sent information. They get sent information and they'll fire information off elsewhere to initiate a response. Now, we are born with the exact amount of neurons that we would ever have in adult life. But synapses, which are the roots and branches that we see here, they begin to proliferate as we move and explore the environment around us, as we stimulate our senses, as we stimulate our social skills and our cognition. And it goes at an explosive rate in typical development in those first 2 years. It's something around 2,500 synapses per neuron to 15,000 per neuron by the age of 2, creating billions and billions of connections. It's incredible. And that occurs through repetition, practice, through, in terms of gross motor development, learning the skill. So I always say with my son, who was feeding himself a yogurt at an early age, he really struggled to be able to feed himself a yogurt without actually turning his food upside down as it came to his mouth. And he needed to repeatedly practice that skill. So then he got to a point where he could do it without pouring the yogurt all over his t-shirt. So what happens past those explosive years is we should go through a process of synapse pruning, where we start to remove those links and passages in synapses that aren't pertinent to us or aren't useful. So my son eventually started to prune that movement where he turned his spoon over, and through repeated practice and development of his skill, he knew he could just bring it straight to his mouth and he didn't have to pour all over his shirt, and daddy didn't have to clean everything again. And that's what should happen in typical development. And then these synapses get stronger and stronger, and the connections get stronger for development of skill. Now, we focus on gross motor skill here, but it's that interlinking play in terms of cognition, social stimulation, language, memory, visual, that all as important as each other, and they all interplay. And this is a really good example of kind of the connections in the brain and how they interplay. And when we think about postural care and active interventions, they're very much associated with positive neuroplasticity. This is taken from cognitive ability in adults, but the same process applies. And it also highlights that neuroplasticity can still occur past these ages. It can still be important. It's maybe just not as prolific. So things like physical exercise, that could be an adaptive walker to get a child moving. Proper sleep, that could be a sleep system to encourage appropriate sleeping postures for more comfortable sleeping. And again, from these international guidelines for children with cerebral palsy, it was highlighted that infant and children have remarkable brain plasticity and aptitude for learning. Taking advantage of this window of opportunity with evidence-based intervention for those with early brain injury maximizes functional outcomes and minimizes complications. So again, we're talking about any child with high risk of developmental delay in this webinar, but it's important that this recommendation is for those with permanent brain injury, because we know the body can reorganize its pathways and structures to overcome impairment. So if it can do it in cerebral palsy, it can do it in other neurological conditions, but also in children where we may not have a diagnosis, but we understand that there is developmental delay. We want to encourage that explosive proliferation of our neural systems through active interventions that are going to stimulate all the child senses and encourage gross motor development. So moving on from cerebral palsy, a really key one that we always use as therapists is typical gross motor milestones. We know that as a rule of thumb, propping up on prone and lifting the head up will be around kind of 3 to 4 months. We know that developments in independent sitting posture may be around 6 to 9 months. We know that pulling to standing might start around 8 to 10 months, and walking might start at 12 months onwards. They're rule of thumb stuff, and this graphic from the World Health Organization helps highlight that the range in terms of what may be typical development is quite wide. Sitting without support between 4 to 9 months, standing alone between 6 and 14 months. It's a good thing to always refer to, because typical development is often not very typical for the children that we care for, and actually it can create a minefield in terms of our thinking and our processes. But what I would always say is that an active approach where all risks are considered and managed is actually not going to be detrimental to the child. If we're encouraging active sitting, standing, lying in combination with maybe more static postural care, it's going to be something that will encourage development overall. If we have an indication that the child is delayed with their gross motor milestones, it's going to be conservative approaches, and it's going to be low risk in terms of our approach. So I would encourage active interventions and active support to encourage lying, sitting, standing, even if we're unsure on the diagnosis. And again, we touched upon gross motor milestones. We'll move on to skeletal posture here. And this is just to highlight how flexible a young child is when they're born. A child, when they're first born, has around 300 or over bones, because over time, as they grow, as they weight bear, as they move in their environment, we start to get ossification of centers. So here we can see, obviously, the pelvis of this newborn isn't fully ossified. We haven't got that connection between all the areas of the pelvis. We've not got the development of the femoral head. There's no patellas. They start to come through use, through weight bearing, through experience. And at that point, the skeletal system starts to become more rigid, starts to become more firm, appropriate for stable sitting, stable standing, walking. But in children that are high risk and severe motor impairments, we might actually have missed the window of opportunity without early intervention in terms of supporting postures that are stable, maybe symmetrical, and also encouraging active function. If we're applying these principles a little bit later, skeletal development starts to hit maturity. And these are examples of what can happen for those with the most severe motor impairments, with the effects of gravity pulling down on their posture, the effects of growth spurts, and the effect of immobility. We've got the example there of Fred, who by the age of 23 had a severe scoliosis and deformity of the rib cage that ultimately led to him passing away and compromising of his vital organs. And then underneath, you can see in just 2 years that a child with a neuromuscular disorder has gone from a fairly well and located hip on the left side to completely dislocated, that would have needed surgical, invasive, painful intervention to stabilize. So why would we not try active, conservative approaches that are low risk but encourage development, not just purely encouraging symmetrical, stable posture? So we're going to switch over to Kaylee in a second. Just a little focus on prone tummy time, just to reinforce. A lot of this you guys will already know, that prone tummy time is a really recommended intervention for those children who are typically developing. We know that being on the tummy is indicated from an early age, that skin to skin contact in particular of mother and baby and father and baby, to encourage interaction, auditory and visual stimulation, encourages potentially that development of that head and neck control and propping up on forearms, and gives us that influence on the early development of spinal posture, that first curvature that we get in the cervical spine to enable us to look and to move and explore our environment. It can be a potentially really important position in typically developing children. Now, how often do we think about it in terms of children who are atypical, particularly at an age appropriate time? What support are we applying for those who are high risk in particular to support the parents to do tummy time and prone positioning safely, to encourage that development and encourage that development of head control and posture and also visual scanning? Are we often applying this later? We know as therapists that those with the most severe deformities, particularly when they hit teenage years, it can be very difficult to position in prone time, and it can be very difficult to change posture from supine to sitting to standing. So they get that reduction in that environmental experience and that enrichment as they get older. So should we be applying these strategies at the earliest intervention, particularly at that point where we move away from skin to skin contact, so we can free up the parents and carers dependence and the child's dependence on them, so then they can be supported in prone, but then still be practicing active play. So postural care and adaptive equipment might do that because it can fit into the home environment, free up the support of the parent's arms and body, and allow them to move in front of the child so they can play and do games and do something stimulating to the child. It should be part of active approaches. And again, this is just some overview of evidence for tummy time. We know that there is a push and a highlight of tummy time in typically developing children, and has been for some time now, so much so that it's now part of World Health Organization guidelines for children under the age of 1. We are also seeing some positive developments in atypically developing children in terms of reducing motor delay. It's a very challenging position, as we said, and it can encourage weight bearing through their arms. It can encourage stretching through the tummy, through the lower limbs, and it can encourage that initial bit for rolling. And that initial development of spinal posture and head control is really important in interlinking to sitting and then to standing. And what we've seen is there is a potential link to motor delay and supine positioning, particularly in the Western world, where, rightly so, there was a push for reducing risk of SIDS through supine positioning overnight. But what we've seen in evidence is the suggestion that potentially that increase in supine positioning was a negative effect for prone positioning and led to developmental delay in terms of rolling and sitting. So it's finding that healthy balance. We know typically parents of typically developing children, positioning prone can be very scary, can be very fearful. I know I was terrified of my tiny little baby boy when I was doing it when he was first born. That's going to be the same in children with atypical development and severe motor disorders. So we need to approach it in a careful, balanced way, encouraging parent collaboration, showing them how it can be safe, showing how active intervention can be appropriate to stimulate and harness neuroplasticity and encourage environmental enrichment. So we're moving on to typical sitting development now. Now, this again be a whole, you could spend an hour on this. So this is very brief, but it's kind of thinking of challenging the kind of perceptions of maybe static symmetrical positioning, but also thinking about active approaches and active positioning, supporting development. Yes, we know building symmetry and stability is really important from what we've talked about in terms of typical skeletal development and posture, but also we want to complement and balance that with encouraging motor skill exploration of environment and an enriched environment for the child. So we know the typical sitting for typical children starts to occur around 6 to 9 months as a rule of thumb. And again, as therapists, are we having that conversation with families in terms of what we're seeing if we are being referred early in terms of the child's sitting ability and skill? And are we thinking about on time or early intervention to influence developmental skill in gross motor skills, development, posture, development, sensory integration and sensory processing, and also harness neuroplasticity through that important aspect of change of posture. As we discussed, developing head control is closely interlinked for then developing trunk control and pelvic control for sitting. We start to get that secondary curve in our lower spine around our lumbar spine to provide that equilibrium in terms of stability for sitting and standing. So it's important to try and encourage that at the right time. We know that it's going to encourage stretching for those children that may be high tone. We know that it's going to challenge trunk for those that may have hypotonia. And again, it's encouraging an approach that's active, not just encouraging seating prescription that fits within the home environment. It's supporting families and the children we care for to explore, to be active. How can we use the accessories and the tools to challenge balance, challenge posture, encourage repeated play, encourage repeated exploration? Are we doing that? Are we doing that to a lesser extent for just purely supporting posture and supporting stability and symmetry? And it's reflecting and reevaluating how we're approaching it. Now, also, we know that it's rare and difficult in terms of early referral quite often, but this is a change in practice, a change in development, particularly in the Western world, that we're seeing these early referrals. So we can respond to that proactively in our approaches and harness neuroplasticity. And as we said, development of sitting posture in terms of structural and skeletal, we start to see those changes in spinal curvature to provide us something that's really robust and stable for sitting stable, but also for rotating, turning, for reaching, for providing that counterbalance that we get from the chin tuck and the head lift in early prone sitting. But then it's remembering that sitting isn't just that 90-90 posture, particularly in those children that are exploring their environments and learning about the world around them. We know that they can develop with wide weight base support ring sitting, but then often they'll move into long sitting, which can be a really good one for stretching out hamstrings, but also then challenging base support and postural control. Moving on to side sitting can help encouraging crawling development, weight shifting, and again, further mobility and exploration in the environment. And then tailor sitting, again, might be more challenging in the balance. Again, wide base support, but allowing for further reaching forward and exploration and playing with toys. It's remembering that 90-90 sitting isn't often the most functional approach. It's appropriate for building stability and supporting posture and trying to prevent postural changes and deterioration within the internal body. But we know that this is that potentially explosive period of child development. So we don't want to be afraid of movement and encouraging different experiences and different movement, because that will also go on to the family and their fears, which is a very, very emotive time when there's a suspected idea of developmental delay in these children or an early diagnosis. And again, I always like to point out information that we kind of use for typically developing children, where there's recommendations in early years to avoid using the molded seats or the bumbo seats, because we know it can infect the natural process of acquiring postural control. Now, that's not me saying that molded seats are not appropriate for children who are atypical, but we need to think about that process of active movement and encouraging active control in these early years and applying it earlier to try and encourage development. If something is very passive, then it leads to maybe a less active environment, a bit less social stimulation potentially. And this is drawn from a resource called EI Smart, which is a framework within the UK, and they provide leaflets for children who are at high risk of developmental delay. And these leaflets are really useful, and they're also come in multiple languages, and they're signposted to into the last few slides at the end. It's something that if you get time after today's webinar to go and have a look and explore and read up on, because it's a really useful resource and website. So again, a very brief overview of development of sitting and some of the factors we need to consider in terms of a multi-sensory enriched approach, and also thinking about development of posture but function. The last few slides we're just signposting to clinical guidelines and expert consensus in terms of early intervention with postural care and cerebral palsy. And there's also signposting to resources from EI Smart and also Cerebral Palsy Alliance, the team that Kathy Morgan and Iona Novak are heavily involved in, and their colleagues, the team that have produced the International Clinical Practice Guidelines for early intervention. And then also to 24-hour movement, which we touched upon briefly, but using those guidelines to give us a movement focus in our practice, and also thinking about those passive sedentary times when we're sitting and when the child's sleeping, and factoring in that balance as a guide for a healthy 24 hours alongside the postural care approaches we do. And then in the last slide, there's also stories regarding our equipment, Ivy with the bee and the monkey, and Lucas with his fantastic development with the Atom chair. And these are all clickable hyperlinks. So everything that you will receive in the next week or two will be of clickable hyperlinks in the PDFs. So just to kind of sum up, I hope everyone could see that. Sorry, Teams has been a real big issue for us today. I do apologise, but all of those slides will be on in the clinical practice guidelines, and the recommendations for early intervention for motor outcomes in children with cerebral palsy will be on that with clickable hyperlinks. And thank you very much for your time today.